A great honor to give grand rounds again at KKESH. This is my farewell speech, so I want to thank you all for the great honor of being here and for your teaching and your kindness to me in my job here. We want to cover some secrets. Being from the outside, I notice things that most people that I think grow up here don't notice. And that is many things, but you're here all the time, so you don't see things from an outsider's point of view. And this is the first thing that struck me when I came here, that the eye surgeons here in the anterior segment department are the best in the world. Now, in many international meetings, it's common for people to give talks which are basically, I am the greatest. That's what the subtitle is. You know, this is why I am the greatest. I am the greatest surgeon. But those people that are giving those talks and trying to pretend that they're the greatest, they don't match our anterior segment surgeons. They don't have close to the experience or the ability. The doctors here perform a very wide variety of patients, and they do a lot of that wide variety. They have the most severe pathology that's possible, and it's a really advanced educational and technical environment. This is key to being a great surgeon because you have to have the best diagnostic and therapeutic tools to use, and you have to know how to use them and practice using them. I remember when I was first here there would be things that I just had never seen before and were puzzling me, and I would ask many people, and I would get many different answers. But one of the uniform answers I used to get was from Dr. Motawa. And he would say, oh yes, I've seen many cases of this very rare thing, and this is how you treat it. And after a while I realized, wow, he can do everything, and he's seen it all. Later I started to think maybe he can't do everything, but close to that. Okay, so that was secret number one. So I'd like to stop and see. Now, since I'm talking to you, I should tell you all that it's really a great honor to speak about this concept of secrets, and this is actually a set of opinions. I'm talking to you about opinions, my own opinions. And I'll tell you that Dr. Malki, when he was a very advanced fellow, I had a chance to teach him, and he would say things to me, and I would say, what? I don't think that's in the literature. And he would say, oh, it's true here at KKESH, this is true. And I'd say, okay, and I'd go to the literature and I'd look it up, and it wasn't there. And so then I would come back to him and say, that what you said, that's not in the literature. And then he'd say, but it's true, it's really true. So now I'm coming full circle and telling you things that aren't in the literature. These are just opinions, things that are not known worldwide, things that I've discovered from being here. So now, Dr. Malki, I'm coming back giving a series of opinions after starting out telling you everything should be in the literature. So, our secret number one is eye surgeons from KKESH are the best in the world. Is there anyone that disagrees with that?
I would like to add, I'm lacking Abdulaziz University.
No. Sorry. No, that's not the topic. But go ahead.
Because, in fact, we have some of overflow patients cannot be done or cannot be accepted by policy from KKESH, referred to us in King Abdulaziz, and we manage them.
Yes.
So
I think those are the patients who have really bad medical problems, and I respect you very much for taking care of those, because the comorbidity here is dramatic, and to be able to manage patients with large amounts of comorbidity is one of the things that makes the great doctors here in Saudi Arabia. So I must tell you, however, I have not been over there, and you'll have to invite me over for a couple of years, and then I'll be able to give you a dispassionate opinion about the difference between the two centers. Anyone else disagree or agree? Yes?
I totally agree, but I think what you mentioned, that these things known at KKESH and somebody who work at KKESH. But what I assume and would like to have maybe the generation who is currently working at KKESH to spread this to outside, to make it in a publication like this. All of us agree on this, but we need it to be in paper and we want to have it in conference.
Yes.
We want these videos to go out, because all of us agree at KKESH we have an excellent service, and they can review their cases and show to others. And this is, I think, what we need.
I agree completely. And when I go back to Johns Hopkins and start there at the Johns Hopkins Hospital, I will be saying this a lot. And when, the residents full of themselves of being at the very best program in the United States and the fellows walk in, I'll say, oh, you don't know anything, All right, so next secret. Anterior Segment Fellowship at KKESH is the best anterior segment fellowship in the world, by far. And I've been fortunate enough to go around the world to many major centers, and there are things about the Anterior Segment Fellowship at KKESH that are completely unmatched in the rest of the world. For example, here at KKESH we have a super excellent foreign physicians. I mean, me, of course, and our other wonderful foreign physicians from outside of Saudi Arabia that bring in a different approach. I'm not saying it's always the right approach, but it's a different approach so that the fellows can hear divergent points of view, divergent opinions, and they can form their own ideas and their own opinions. The homegrown consultants here, Dr. Khaled is a great example, are just unmatched in terms of experience of the most severe disease possible in the eye. And they have so much experience that they can pass this experience on to the fellows. The fellows, the actual numbers of surgeries are better here than they are anywhere in the United States, and I'm sure most of the world. I mainly know North and South America, but certainly unmatched in North and South America. There is no cost limitation to the fellow surgery here. This is a dramatic thing. Now in London, in England, they're going to have big impacts. Anywhere in the United States, anywhere in Western Europe, there's going to be a big impact on how much a procedure costs will have a big impact on the ability of the fellow to do it, or even on the performance of the surgery. The same is starting to be true in the United States. And here, that's not even on the list as far as things to worry about. The poor fellows here have to go through a rigorous testing process. It's much harder now than it was when Dr. Malki went through the fellowship. The poor fellows, had to take, this year to graduate, had to take a 200 multiple choice test, 200 question multiple choice test, and then sit in front of a board of 5 consultant ophthalmologists, 2 from outside, and pass these rigorous tests. Here you have a wonderful infrastructure for research, and you can just walk over and talk to an epidemiologist, no problem. You can design any study you want, and there's a huge amount of clinical knowledge to be gained. So secret number 2 is Anterior Segment Fellowship at KKESH is the best in the world. I have a question.
Any comments? And by the way, for the Anterior Segment Fellowship at KKESH, all the Saudi consultants almost, they are graduate of KKESH Fellowship, so they are, they share us this thing. Okay.
So, no disagreement with this point? Fellows? No? Okay. Okay, secret 3 is something that I think is unrecognized. This takes a lot of our time in the anterior segment department. This is a new syndrome. It's never been talked about before, never been described yet. Today's the first mention of it. And this is the Riyadh anterior segment syndrome. Usually in the subspecialties, we identify single diseases and treat them. And of course, a syndrome is when these diseases are grouped together. And here, a large number of diseases are grouped together. Dry eyes, vernal keratoconjunctivitis, climate droplet keratopathy, stem cell deficiency, dense cataracts, amblyopia, and keratoconus. These things, we think of them individually, but they're not. They're but part of a syndrome. They're part of a progressive problem, which starts out with vernal keratoconjunctivitis in childhood and then develops into keratoconus. And because it occurs, this keratoconus, in the amblyogenic age range, these patients as adults tend to have amblyopia. Then, so it starts out at this this way in childhood, and then they develop dry eyes from the chronic inflammation. Then the BKC, if it's untreated, will develop into a complete stem cell deficiency and result in a pannus growing across the cornea, and finally the most dense nuclear cataracts anyone can find. I did a study with one of the fellows on the density of presenting cataracts in our operating room, and the lens opacities classification system grades cataracts from 1 to 6 in terms of their density or opacity, opalescence. And we had to make a 7, because the way you grade these cataracts is you look at a picture and you say it matches this one of these 6 pictures. But we found that about 11% were 7 out of 6. And we had to make up another category that was just white cataracts. That turned out to be about 5%. So my point about this previously unreported syndrome is that it can be stopped if we intervene early. So what causes Riyadh anterior segment syndrome? Summer. Summer in Saudi Arabia causes this. You all are from this country, so you don't notice that when you come here from outside, it's really hot. It's really hot. In the summer, the cloud cover disappears, the wind speed is high, it carries this fine dust. There's a complete evaporation of the tear film on our patients, and the dust is embedded into the ocular surface, and it causes an inflammatory reaction, a chronic inflammation. This lack of cloud cover exposes the eye to high levels of UV radiation that happens in the summer. Chronic inflammation slowly destroys the accessory and primary lacrimal glands, and the chronic inflammatory response causes the children to rub their eyes a lot, leading to keratoconus. So, I looked on the internet about Riyadh, and I found this chart. It's a fascinating chart. First of all, you see in red the temperature. Okay? Notice the temperature in red is so high, it's not even on the chart for 4 months. So those 4 months are the bad months of summer. Now, so the purple is the average temperature, the blue is the bottom temperature, and then the next line, and then this gray line is the relative humidity. So it drops down to just 10%. Of course, 100% is rain. So just 10% for 4 months, and this is extremely low. Now, notice the green bars. Those are wet days, and so what that really means is cloud cover. So there are no clouds for 4 months. Now, that doesn't even talk about wind speed. So I found this chart on the internet, the daily wind speed, and I took the color where Riyadh is, and I did some conversions, and I found out that on average here, every day, the wind blows at 14 kilometers per hour. That's just average for a whole year. So this is like having a hairdryer pointed at your eyes all day long, all year round. And I'm sure, this comes as no surprise to you all, but I will use this when I go back to the United States. And I think you may recognize where this is taken. When I have visiting professors who I'm walking around with, they say to me, "I want to see the desert." And I say, "Look outside. That's the desert. That's the most harsh desert in the world." And when I was in Los Angeles before I came here, and people would tell me, "Oh, it's so hot in Saudi Arabia," I'd say, "Oh, Southern California, we have the Death Valley, we have Mojave Desert. If you've ever taken the drive from Los Angeles to Las Vegas, it's very, very hot. But there's shrubbery everywhere. There are these desert plants everywhere. Here, it's too hot for that. You don't have plants. We have really high winds in Los Angeles called the Santa Ana winds, and they blow so hard, they blow over trucks, they blow over big trees, but they don't carry dust. This is a much harsher environment for the anterior segment. So, I'm writing this talk, and yesterday, this child came in to visit with me. Trod, are you here? Trod Kadi? Okay, so this child shows a lot of things in this one photo. Notice that there are periorbital hyperpigmentations, and this is allergic shiners, we call them. And so this child has an inflammation of the eyelid's anterior segment. And if you look closely, you can see that he's got a left esotropia. So he's already got amblyopia and vernal keratoconjunctivitis. He's sent in to me for evaluation. I'd been here about 2 years, almost, or maybe a year and a half, before I noticed with Dr. Kadi working with me that, hey, all these patients with VKC, they all have keratoconus. Well, it turns out not quite all, but almost all. So then I did a pentacam on this 7-year-old child. This side is fairly normal, but this side, this is a bad photograph, whoever took this is not a good photographer, but it shows that already in the 7-year-old, in the right eye, there's posterior elevation that meets criteria for keratoconus. And then last week, this 8-year-old child came in, before I even had written this talk, but I was thinking about it, and he's also got allergic shiners. Luckily, he does not yet have keratoconus. And what you might notice is, if this is really an accurate pentacam, that in the right eye, he's already too thin to cross-link. So he has keratoconus and VKC, 8 years old. So that's the beginning of Riyadh anterior segment syndrome. And so it's much better to prevent disease than treat it. So how can we stop Riyadh anterior segment syndrome? Sunglasses, number one, sunglasses. And I did notice right away that my eyes were becoming dry when I first came here. And back in the United States, I used to own a small optical shop. So I called them on the phone and I said, send me those motorcycle glasses. So I've carried them with me in my pocket every day ever since I've arrived. And these things are great because they form moisture chambers on the eye. Old-fashioned treatment for dry eye. They block out the sand, they block out the wind, and they block out the heat from directly impacting my eyes. Now, even though I wear this every day, I now have dry eyes. So another thing I often recommend to my patients is moisturizers and air filters. But, they kind of shrug it off, don't really listen to the crazy Amriki, and especially when I tell their grandfather that he should be wearing glasses like this. So how can we stop RAS? Also limiting outdoor summer activity in children. That may be hard to do. So that all leads to secret number 5. VKC in Saudi Arabia is a serious blinding condition.
There is no presence of the hospital in the public, in the media, because this thing you can educate people about. It's too late for a child to come with keratoconus and vernal. What we can do is, most of the time, very limited. But I think the hospital, being the institute that faces a lot of such a thing, is responsible, not only in trying to treat, but also in educating people. It has to make its own, approach to the Ministry of what they call it.
I agree with you completely, Omar. And there is
but this so far is not done,
Yes, it's not done, but part of that has to do with just inactivity on the part of the medical staff, and I must admit that I didn't really understand this when I was on the patient education committee. And we do have a wonderful patient education committee here at KKESH that sends out text messages of patient education. So, and I suggested some, but I was thinking as an outsider at the time. This is something you tell everyone. If you're diabetic, get your eyes checked. I mean, that's true throughout the world. But you're right. There's a place for this particular concept, and it would disrupt this progressive disease at an early phase.
And even, visits can be arranged to schools.
Sure.
With a portable slit lamp, and they can, at least the aggressive cases or the obvious cases of allergic keratoconjunctivitis can be picked up.
Well, we have that outreach program. I think that would be a great thing for the fellows to do.
The outreach, they leave KKESH and then just go to another hospital. They don't do this sort of thing.
Yeah, but we can, I think, with modern technology.
Visits to schools.
With modern technology, I think we can place a camera on them and look at where they are every moment, or some kind of tracking device. Thank you, Omar. Any other comments or agreements, disagreements?
Thank you, Dr. May. I agree with all what you mentioned, and it's really serious disease, VKC. Unless we discover it early and treat it early, we'll have all the sequelae and the complication of the disease. Education, we have the very active department here, and they are doing their job well. Plus the outreach, we are doing our job, and our aim is to treat there. And one of the things which we already planned with you personally, to have this visit to school and these things. So everything is planned. The problem which we face with the VKC, especially with the children and even with all people, they used to take medicine for some times. When their eyes get quiet, they stop, and they come back to even severe attack again. And the other things which is more serious, they go to the pharmacy and they used to take steroids, and this will make their eyes itching less, make their eyes wide without any redness, without these things. The serious problem even with this, it might lead to glaucoma and all the complication of steroid use. So this is something which need things from MOH itself, and I already contact the MOH for such things, at least steroid not to be prescribed from pharmacy without prescription. So this will avoid many things and many complications. The rest of the things, I'm sure you cover it in a very well way, and I hope VKC, because Saudi Arabia, one of the highest country, they have the VKC and its complication. So it's not just only in Riyadh. When you go to south, it's there. When you go to north, it's there. So it's something which for the whole country, and we have to put a lot of effort to treat this problem. Thank you.
I agree. Thank you, Saeed.
Thank you, Dr. May. In this point, which is secret number 4, I would a little bit disagree with you.
Okay.
Because what we are seeing at KKESH, well, this is what we usually say to residents and fellows, this is an artificial thing. You cannot apply this to all Riyadh. You cannot apply it to all Saudi Arabia. This is a tertiary hospital, and in fact, it is the referral hospital to all these complicated cases. What you are seeing here is something maybe you'll not see it in the other center in the main city as well. So
certainly the sample is biased. Yes.
Yeah, and in fact, sometimes you will see more keratoconus or VKC if you go south, and you may have less if you go north. But still, we need to keep in mind that KKESH is a referring hospital, and most of the cases are the difficult one, which need tertiary care.
So you're thinking that probably I could be possibly overreacting because of the biased sample, and that it could be that this is not as much of a problem as I think it is, which is a valid point, I think. Who? You're the moderator.
But if you say like RAS,
it's not RAS, it's probably Saudi Arabia.
Well, I'm only talking about my own experience. And you all are so much more experienced with the rest of Saudi Arabia. I've never really examined patients in any other city. Okay, to Saudi Arabia, anterior segment syndrome. Okay. Oh, ISIS. I like that. It's really scary. We'll get attention.
Assalamu alaikum. This is Abdi. I'm an ophthalmic assistant at Clinic 5. I have the pleasure to work with and the honor also to work with Professor May. And I want just to say that as assistants and as technicians, we are facing those patients that are coming to the anterior segment. And my point of view that we have a corruption in the referral system in all of the regions of the country. So when you mentioned, sir, that about the problem with the VKC and the keratoconus, I think when Some mentioned that we have from the southern region. I think this is 80% of the patients that we are receiving actually in anterior segment department, specifically that they didn't have the chance. I mean, I'm sorry to say that about our system, but we have a corruption in the referral system. So no, mostly they don't have the chance to come to KKESH. I mean, even the advanced cases. But when we mention the VKC, I mean, unfortunately, we have a big project when we have the John Hopkins contract with KKESH. But unfortunately, I mean, the social media, I mean, Saudi Arabia have, I think, 70% of the population, they are young. We are the best people using the social media in this country. I mean, for example, Twitter, Snapchat, all these young people, they are coming to KKESH, they're using the social media thing.
That is a really good point, Abdulillah.
Yeah, but
we should have an Arab Spring of VKC.
Yeah, I wish that we have the education to use a new, techniques, a new approach to unfortunately, as a screener, as an assistant, when I screen the patient and I'm asking him about the reasons why he's not using his medication, for example, when Dr. Mutawwa mentioned that they unfortunately, because there is no clear path for the patient when he have refill medication, for example, I don't blame our institution or our hospital for a long waiting appointments. I feel sad for all the patients, but I mean, also it needs the efforts from all the departments in this hospital, and from our also MOH, because when we see it's a silly reasons that when we see all those patients, they are lost in the system, for example, or they are lost for his medication. This is what we are facing really daily basis with those patients. We feel sad. Even I feel sad for our physicians, for Dr. Malki, for example.
I feel sorry for myself.
They are overload themselves. They are overload their schedules to give them exact appointment, to follow up with them, to try to educate them about their medication. So
I think your point, Abdulillah, is that we should be using the social media to educate people.
Yeah, because I think, and you are, from your point of view, all our patients are young, especially in those conditions. The VKC and the carotid.
And they probably have teenage brothers and sisters that are on Snapchat, and they can take care of themselves and their siblings.
By the way, this is a good opportunity to really, it was an honor for us all as assistant in behavior. I'm talking about our technicians in this hospital. Really, it was a pleasure and a privilege to work with you, honestly. And I will be as a witness. I will say this is the first time, honestly, I saw a foreign physician coming to this hospital and love our people. You love your patients. I saw the relation between you and your patients. Honestly, this will make us sad and I saw this is in your in the eye of your patients when they know that you are leaving. Thank you for your time, your education. I saw even your students, your fellows, and how's the relation between you and them, your patients. So really, we are happy for you that you will have a new level in your career, and we are sad at the same time that you are leaving us. But believe me,
thank you very much, Abdulillah.
You give us a lot. Thank you so much, Dad. Thank you so much.
It's very kind of you to say those kind words, and I would respond to your comments with some interesting things that I've noticed when I was about KKESH. Yes, like any big institution, it has a lot of problems, like all of them do. But something that really makes KKESH run is the individuals. It's the way the individuals work together, and there are people in this institution that really care about what happens. And I mean the guys from security, everyone. They really care about keeping this place running. And it'll be a pleasant shock when you run into this when I run into this from time to time. And that's why KKESH runs. Yes, thanks to our administration, thanks to the Ministry of Health, thanks to the King, but it's the people that work here, that live here and stay here on a day-to-day basis and make this place work. It's a group effort on all of your parts. And I think you as a group are under-acknowledged for this. Okay, so not too much disagreement on 5. By the way, 5 was really 4, but it sounds better to have high numbers. Okay, secret number 6. Keratoconus in Saudi Arabia commonly causes amblyopia. So the incidence, when I first came, I was noticing all these people with decreased vision that shouldn't have decreased vision who had keratoconus. The incidence of amblyopia as reported in the United States is 2%. But these keratoconus patients, it seems like almost everyone has amblyopia. And keratoconus, from my opinion, may cause anisometropic amblyopia or isoametropic amblyopia. That's bilateral for those of us that are not pediatric ophthalmologists. So this is the point about keratoconus in Saudi Arabia. This is not at all in literature. People don't acknowledge this. It's only an opinion on my point of view. It's never been described. And that is, keratoconus in Saudi Arabia can begin in the amblyogenic age range. So we usually think of keratoconus as a disease of the second decade. So this is first decade. In fact, early in the first decade, it's starting. And otherwise, you can't account for this very high incidence. So this is just an opinion. There's nothing in the literature about this.
Okay, and we noticed in KKESH that most of those patients, keratoconus and amblyopia, they have VKC to start with. So VKC, continuous wrapping, with very young age, very elastic cornea, it will progress to keratoconus, and he's in amblyopia age, and the problems will start. And I think every patient with moderate to severe VKC in childhood, he has to have at least one per year a topography, because many patients with moderate to severe VKC, they are wrapping a lot in this very young age. They will come with first topography, mild keratoconus like high Ks, posterior float slightly high or borderline, and the next follow-up after 1 year or 1.5 years, he will come with frank keratoconus to a degree that you cannot even cross-link him. So this is really common. I saw it more than in a lot of cases. Any comments?
You're moderator. I agree with you, but this is depend on the patient, either if he has or she has VKC or not. For the normal keratoconus, most of them, they don't have amblyopia. But for those having VKC, they usually have the amblyopia. The other things here with the dryness, as you mentioned, I used to mention all patients, not only for even regular patients, to keep hands away. And this is I'm telling the fellows and residents, because this is the mechanical induced keratoconus. By rubbing the eye, it's keep breaking the cornea and desmet and all these things. So this is one of the advice to the patient to keep hands away. Even if you feel itching, there are other things to either use cold compress or the medication, tear natural, whatever, lubrication, and this is important. So usually amblyopia most of the time happens with patient who's having VKC.
Saeed, I'm so happy that you agree with the concept of Saudi Arabian anterior segment syndrome, because that's the beginning of it. Any other comments? Tariq?
Thanks, Dr. May. So what if we catch a kid a little bit early and we could manage his rubbing issue? We give him anti-allergy and he doesn't rub anymore. What's the possibility or chances to have keratoconus? Does that decrease by stopping rubbing, or it's like association?
Excellent question. And you, as a young ophthalmologist, should be answering it. Okay. All right. Secret number 7. All patients in Saudi Arabia have dry eyes. Even me. I have dry eyes now. And by the way, sometimes I rub my eyes. I'm sorry, Dr. Matawa. So In the United States, dry eye is a problem. Some people have it, other people don't. Here, everybody has it. This is a problem from an educational point of view. For someone who's in charge of educating fellows, I just have not had the heart to teach you guys all this stuff about dry eyes because it's normal. Everybody has it. Why do we even care? You know, it's like everybody's got brown hair. So what? You know, what's the big deal? Use artificial tears, do all the things you do for dry eyes. There's a lot of things to do. It's not what the topic is. But once again, it's summer. You know, it's part of the Saudi Arabian anterior segment syndromes. Part of it is dry eyes, the constant heat, the constant wind, the lack of cloud cover causing ultraviolet damage to the surface of the eye, dust, chronic inflammation. By the way, the lack of cloud cover works two ways. One, the clouds block out the ultraviolet, but when you take the tears off the eye, you're taking away another blockage for ultraviolet damage to the eye. Any other comments on Secret 7? You're the moderator.
We can add now using a long time for the computer and also the mobile and these things. Nowadays, children coming with dryness. And I used to even below 10 years, and they are using their mobile, their whatever computer for many hours. Some of them, they are using it for more than 15 hours per day. And this is lack of blink and distribution of the tear. So this is, I put it now, number one, especially for young people. And this is important to advise them because this is will not affect just only the eye, also for the neck, for the cervical, for all the, and they get headache, they get all the syndrome. Okay, so I put it nowadays number one, especially for those below 30 years of age.
Ah, interesting point of view.
Well, I disagree if you say all, but if you say the majority, I will agree. And we'll add to the factors here in the environmental factors, the air condition. The air condition will dry the media and will add to the dryness. And the computer, actually many people are working on computers and they work for hours. And as we know, when you are concentrating, you don't blink normally, and this will add to the dry eye syndrome. But here I would say many are, it's a common problem, but it doesn't affect all people.
Well, that's I like your scientific approach because always is always wrong and never is never right. So it's probably wrong as far as always, and maybe it's a little overstated, but I think that if you use the evaluation that we use in the rest of the world for dry eyes, you would find, you know, level 1 in almost everybody, and it depends on what you mean by dry eyes. So there are many ways to describe this, and
category. Some people will be away, they will have no symptoms, and you examine them, they don't have signs of dry eyes.
Okay, but there's, you know, the way you evaluate dry eyes is both by history and by multiple stains. So it's, you got to do lysinamine green, you might have to do even impression cytology, and have them answer a battery of questions. So I think this is another thing for Tariq to study. He's a young ophthalmologist in training, and we should have him find out, you know, what the real incidence is. I think it's high. I think always is always wrong. Yes, so far. We haven't finished the secrets. Yes. Yes, Omar.
Yeah. One comment about the role of clouds in ultraviolet. Actually, sometimes you can have clouds partially covering the sky, and you have an increase in the ultraviolet exposure. As long as the sun disk itself is visible, you get the opposite. You don't get a blocking effect. Only when you have a proper cover of clouds, then the ultraviolet index gets less. The other thing is about the mobile and the role of mobile. And you know, in some patients, who undergo keratoplasty, we noticed that they do not heal until you issue an order of discontinuing the mobile. And they heal in 1 or 2 days.
Interesting. Fascinating. I'll have to add that to my clinical repertoire.
Really, that's true, yes.
But as far as the cloud cover goes, I have had this debate with my friends in the United States. I say, oh, you don't know how bad it is in Saudi Arabia. It's the worst anterior segment environment. It's got so much ultraviolet. And they say, oh, come on. What about all the other equatorial countries in the world? And at first, that silenced me. But then, I've been living here for a while, and I realized, wait a minute. Yes, all those other equatorial countries have the same vertical sun exposure, but they don't have the lack of clouds. I really think that's significant, and I also think that the relative humidity causes refraction of the light away. It's a prismatic effect of water. So some of that light is going away. Now, and most of it is the ultraviolet, because that's the part that's most easily refracted. That's, of course, why the sky is blue.
Can I add something for
Sure.
the mobile devices, because this is very important. I don't think that teenagers especially will listen to us when we say don't use, limit use, or whatever. There are some hard rules at home, but I think we should educate them of proper use of especially blinking. I think this will always make this as a remnant of the wiper in the car windscreen. I think then I said if you blink more often, you will protect your cornea. And I think this is what we should tell them, because also there are bad things about mobiles, not only on the sort of pathological or anatomic, but also driving them from social interaction.
Yes.
Now we are more individualized. Sometimes even I'm at home, everyone is talking to himself.
Yes.
And this is absolutely unacceptable in our social life. You get the point?
I agree completely.
You can add mobiles with sprinklers.
Say that again?
You can add mobiles with sprinklers on the outside.
Yes, we can have mobiles with sprays. Okay. All right. Here's another thing I've learned. Oh, I'm sorry.
Just a comment regarding the mobile use, and we used in the past to educate patients regarding the reading habit and the good reading habits. Nowadays, I used to do it in my clinic to educate them about how to use the mobile. And this is the most important, not to just, nobody will listen to you if you ask them to stop. Even yourself, you will not stop. But the way how to use these things, and even with family, all of them, especially with young patients, they will complain to you as a doctor to just give him order not to use these things. So you start telling the patient or the young ages people and also their family how to use this and the frequency, and also at least to recognize this will lead to a problem. And not always I'm concentrating, because most of them will complain of headache and these things. It's not just only the eye problem. It's also cervical problem, which is the most important in future. And they will lead to even more serious problem with their cervical and neck.
I like your holistic approach, Dr. Matawa. Okay, so here's number 8. And this relates to number 1. Number 1, we have the best surgeons in the world here. And this is the center of Big Bubble for the world, so let me give the background to the residents. The treatment of choice for keratoconus, if there has to be surgical intervention, is lamellar keratoplasty. Here at KKESH, we do the Big Bubble, where it was developed here. And the point about the Big Bubble is that it uses air to separate the tessemeous membrane and corneal endothelium from the stroma. And then you can maintain that separation during surgery. And then you put a new cornea on with no endothelium, and you use the host endothelium so it can never be rejected. And the Big Bubble is the best visual outcome compared to leaving stroma. You can do lamellar keratoplasty leaving stroma, then you get an interface and decreased vision at first, which then improves with time and comes up to about the same as the bare Descemet's Big Bubble approach. So, this is just my opinion, but now I've been here for a while. I can do the Big Bubble. I can teach the Big Bubble. It's really hard. The most successful big bubble reports are from here, Anwar and Teichmann reporting 89% success. Other success rates around the world vary. It's usually around 70 and it drops to 50% in some centers. This is a difficult surgery, and it takes excellent surgeons who you do it all the time to do it at a high rate of success. So I know Dr. Motau has explained to me that we do big bubble because the teenagers or people in their 20s have to study. It's an important developmental time in their life, and so we can give them clear vision, and I think that's great here at KKESH. It works. But at the rest of the world, where we don't do that many big bubbles, it's very hard, and the success rate is low. And when you drop your success rate down to 50%, you're taking 50% of people and giving them new endotheliums that can be rejected. And we've all seen in our clinics these patients that get these rejection after rejection, and then they get glaucoma and all kinds of bad things happen, and then they end up with Boston keratoprosthesis, and then maybe eventually we call Dr. Osorio to put in the tibial bone prosthesis. So I think when I go back, I will take the Don Stone approach. Now this is something last week talking to Dr. Stone just hit me. Oh, he's so right. Make a big graft because you want to manage the ectasia, because the ectasia can progress in the host tissue peripheral to the graft. And then you just leave deep layers of stroma, and I'm not advocating this for KKESH, I'm advocating this for the rest of the world.
At this point, I have to add that even the routine surgery for Dr. Khaled and Dr. Said Mutawwa, and unfortunately, I'm one of them, dissection. Yeah, because it is breaking my neck. At the time consuming, but we have to do it for most of our patients because they are complicated with a lot of vascularization and VKC, unfortunately, so it is abnormal service. Doing a PKP in those patients, very risky, and most probably it will fail and a lot of consequences will happen. I don't know if you have any comments?
Actually, I stopped doing the big bubble. Yes, I don't do it anymore. I do deep dissection with the help of fluid hydration, and I go very deep. And sometimes, most of the time, you can show it to someone, and they will comment that this is a graft, a BKB. Or sometimes, if you say that this is big bubble, they say, okay, this is big bubble. Look at it; it's very clear. And I noticed that those with residual stroma that you leave tolerate trauma very well. Compared to those with big bubble. You see patients with big bubble, after blunt trauma, everything gets out of the eye, including the lens. Sometimes they get retinal detachment. With those with residual stroma, they get some of the sutures broken and the eye remains closed. The other thing is, I have patients with 20/20 vision with residual stroma left, so the interface opacity is not an issue. It depends on whether your dissection is smooth or not. If you leave if you cut a lot of collagen lamellae, severe a lot of collagen lamellae, ultimately you will get a haze, even subclinical. And this may degrade the vision. But if you're dissecting more or less in one plane, you end up with a uniform. And the clue to this is patients who are having LASIK. They have stroma on stroma, and then they can have vision better than 20/20. Even so, the other thing, we have many patients with deep scars, or vernal or pillosid, that you need to go deep, and in my opinion a bubble is even contraindicated in those patients unless you want to get into trouble and convert to BKB. Even with a 90% success rate of big bubble, I'll not try it in someone with vernal or with pillosid marginalization, where you go almost close to the limbus.
Okay, thank you. Dr. Khaled.
And even with trauma, dissection, LKP with dissection with trauma, many times I saw it, the patient has trauma, 6 or 7 sutures cut, and did not perforate. I mean, yeah.
Actually, regarding the deep lamellar, when we started, myself and Dr. Teichmann, in the beginning, we just only remove superficial. and we used the drill, the one which we use for pterygium, and there was no complication. Even when we have perforation, we put histocryl glow, and especially for those with the VKC and this, and there was no complication. So we do all the phases and all types, deep, air bubble, but those with the almost blinding disease, VKC, with the vascularization, and I just try to give them their way to see, at least to help them. And unfortunately, it happens during the early years of their life, and this is important. So I used to do it as much as I can dissection. Now I'm doing just only one shot per decimet, and maybe fellows knows that. And it's just when you take your make your line from the beginning, and you can spread the tissue. It is just only you can push it, and you can separate it from the decimet. So this is important for the deep lamellar, at least for those with high or the complicated VKC, to at least not to get them blind the rest of their life. So I always try to do LKB as much as I can, even if I put glow to prevent BKB, because BKB is in most of the cases will be ending of their vision and getting blind. So this is important.
Thank you, Saeed. I'm being told to rush, so I'm just going to flash the last slide, and this was specifically designed for Dr. Kirat, because I thought he might disagree, and that femtolaser is indicated in corneal clouding, loose zonules, and white cataracts, and the reason I'm saying this is that femtolaser penetrates cloudy corneas. This is something that's not known in the world. As far as loose zonules and white cataracts, those are known. And I think the point of this talk is to stimulate Tariq to do lots of research projects. So Tariq, I have 5 of them here for you. These correlations are not in the literature, and they're here, and I'm convinced of them, but I have no proof. So we need you to do these 5 comparative studies, incidence studies, and as our new chief fellow, if you want to assign other fellows some jobs, it seems reasonable that you could work with Dr. Stone to, discover the truth about these issues. And lastly, I want to say that this is my goodbye. This has been a fabulous experience for me as an American. Most Americans never live outside the United States. So we watch it on the news, but we have no idea what it's really like. And when I return, I'll be returning with a very rich experience. Knowing people in another country, working with them for years has been a great honor for me and extremely enriching. And to my fellows, thank you so much. You're a wonderful group, and I'm extremely proud of you. It's the best thing I've ever done. To Clinic 5 staff, thank you for being my family away from home. My faculty, thank you for putting up with me and letting me be your servant and getting things done. Thanks to the excellent nurses in the OR, surgical video department, research department, and my friends. You know who you are. I love you like a brother and a sister. Thank you.